Hello, I'm Kirk Garrett from Lenox Hill Hospital in New York, and it's a pleasure to tell you today about our findings regarding an increased risk of ischemic complications with withdrawal of prasugrel and aspirin among patients who are treated with the Liberté paclitaxel-eluting coronary stent. David Lee from Stanford and I were asked to serve as principal investigators for the TAXUS Liberté post-approval study of the Liberté coronary stent. That's a registry study intended to provide information about the performance of the TAXUS Liberté stent when it's used in a broad spectrum of patients typical of our clinical practices. At the same time, the dual antiplatelet therapy study was being constructed, and as you know, manufacturers were asked to provide patients for the study. Boston Scientific elected to provide TAXUS Liberté patients from the TAXUS Liberté post-approval study into the DAP study. That provided us an opportunity to see how the TAXUS Liberté stent would perform in the context of that study. And importantly, it provided an opportunity to treat TAXUS Liberté stent recipients with a combination of aspirin and prasugrel as the dual antiplatelet regimen. Approximately 4,200 patients were recruited into the TAXUS Liberté post-approval study, and of that group, about 2,200 were enrolled into the DAP study. 1,093 were treated with 12 months of prasugrel plus aspirin. 1,098 were treated with 30 months. What we observed was an important difference in the co-primary endpoints from the DAP study: major adverse cardiac and cerebrovascular events and stent thrombosis, when patients were exposed to a longer period of therapy. In addition to that, our data monitoring committee observed that when prasugrel was removed from study patients, whether from the 12-month cohort or the 30-month cohort, an important increase in the rate of accrual of additional ischemic events was found. This seemed to imply that withdrawal of the protective effects of prasugrel was important to patients, whether that occurred after 12 months of therapy or 30 months of continuous therapy. On the basis of this observation, the TLPAS Data Monitoring Committee recommended that we unblind patients from the TLPAS population that were participating in the DAP study, so that those patients who had been assigned to 30 months of treatment would be given an opportunity to discuss with their doctors whether or not they should continue prasugrel in an unblinded fashion beyond 30 months of treatment. We found that with regard to the co-primary endpoints, prolonged therapy was associated with very substantial risk reduction. The principal risk reduction was seen in myocardial infarction. And importantly, myocardial infarction related to stent thrombosis and myocardial infarction not related to stent thrombosis were both importantly diminished. Stent thrombosis rates were also lower, but importantly, we wanted to see what the bleeding rates would do with longer therapy. To our pleasant surprise, we observed that although there was more bleeding with longer therapy, as expected, the difference in bleeding rates did not seem to be statistically important, and there was no signal of an increased risk of serious bleeds, including lethal bleeding or intracranial hemorrhage. On the basis of these observations, we concluded that patients treated with the TAXUS Liberté paclitaxel-eluting stent and prasugrel plus aspirin ought to be treated for a period of not less than 30 months in order to assure optimal reduction of ischemic events. Beyond that, we're not sure how long patients should continue dual antiplatelet therapy. It does appear from the data that we have that therapy beyond 30 months would be beneficial, but the optimal period has not yet been defined. We look forward to conducting more study in this area, and particularly understanding in greater detail the circumstances that resulted in an increased risk of ischemic events following study drug cessation in 30 months. Thank you very much.